Hello, everyone. My name is Alexander Nam, and I'm a law clerk here at Lowes Parker. Welcome to today's webinar hosted by the Home Care Association of Louisiana. Today's webinar is entitled Home Health ADR, TPE, CERT, and UPIC audits, top denial reasons and the possible impact of these audits on other enforcement actions. Today's presenters are Meaghan DeBenedetto and Christin Thompson. Meaghan is a senior associate here at Lowes Parker and is a certified professional coder. She has also had experience working for a home health care agency before attending law school. Meaghan has experience with auditing claims, identifying deficiencies, and assisting clients in improving their documentation. Meaghan also has extensive experience working on compliance plans and developing policies and procedures for a variety of different medical providers. Our next speaker, Christin Thompson, is a senior associate at Lowes Parker. Before joining Lowes Parker, she worked as a professional coder, assigning diagnosis and procedural codes for urgent care, inpatient and outpatient facilities. She has experience identifying documentation deficiencies and auditing claims for a variety of practice types. Christin assists providers nationwide with developing and implementing policies to improve documentation and coding practices. As a quick reminder to our viewers, if you have any questions throughout the presentation, please feel free to type them in the chat box. We will address as many as possible at the end of the presentation. Without further ado, I present to you our speakers.
Thanks. If you could go on to the next slide. Just quick disclaimer, this presentation is given for informational purposes only. Your situation can vary based on your individual facts and circumstances of your case. And please reach out to counsel to discuss if you have any questions. Okay, you can go on. We're first going to discuss TPE audits. The TPE audits were paused during COVID, but have fully resumed now for some time. And you may have already received one or been involved in one since then. On this slide is just some background on the history of TPE audits. Basically, they began in 2014 and have been evolving since that time and have kind of been updated or modified a bit. TPEs can either be prepayment or postpayment, and they involve your MAC focusing on a specific provider or supplier that bills a particular item or service, and we'll go into that a little bit more. You can go on. It's your MAC's job to review treatment documentation and cut down on improper payments. That's part of their contract with Medicare. The MAC, which is your Medicare administrative contractor, they run the TPE, which is the targeted probe and educate process, and they select the providers to be audited based on a number of different indicators. It could be your billing patterns, improper payment rates, etc. There are many different reasons you could be selected for this process. And once you're selected, the standard process would be that you'd have about 20 to 40 claims be selected, either per provider or per item or service. So, one practice could have multiple TPEs going if they have different providers being audited. For home health hospice, it tends to be more focused on the per item or service, so 20 to 40 episodes of care. These would then be audited, and you usually receive the corresponding education for any denials that you will receive through it. There are some circumstances where more or less claims can be selected, but this is what you would typically expect is about the 20 to 40 claims. The TPE process is 3 different rounds, and you can be discontinued from the process whenever you're deemed to be compliant. So just because it starts doesn't mean that you will go through 3 rounds, and in fact, you very much hope that you will not. Each MAC sets their own standard to determine when a provider has been determined to be compliant and can be removed from the process. Some of these are stated publicly on their website, or they will tell you if you ask what it would take to be considered compliant and be removed from the process. Others will not tell you, and there's really no way to know. But if you go through all 3 rounds and you're still not determined to be compliant, then you can be referred to CMS for further action. So obviously it's very important that you try to increase your approval rating as high as possible, especially if you don't know where that line is. It's often in the 80 to 75% range in order to be discontinued from the TPE process. But again, each MAC sets their own standard, and they may or may not tell you what that standard is. Okay, you can go on to the next slide. When MACs are selecting who to audit, they typically are looking for outliers. So this is commonly done through data mining. They look for things such as a high volume of services, high cost, a dramatic change in frequency of use. So that could be up or down. So if your services you're offering change drastically, that could be a reason. A big change year over year, again, up or down. Really any change or statistic that makes you different from other providers in your area all can affect whether you're selected for the TPE process. So specifically for, home health or hospice, well, really home health. If you provide, say, more wound care than another or the standard offices, or if you do more physical therapy, OT, ST, any of those could result in them taking a look at you. Now, that doesn't mean you're doing anything wrong. There could be a very good reason. You could be the provider in the area that has a really good PT program. And so patients who need a lot of PT get referred to you at a higher rate. So that's why you're offering more than others. So just because you're an outlier does not mean that there's anything wrong. It just increases the likelihood that you might be selected for a review. And if you're selected for a review and you're documenting things correctly, then you'll get passed through the TPE process and approved, and it's fine. But of course, no one really wants to be audited or go through it. The time, the expense, the headaches can be, quite burdensome. Providers can also be referred to the TPE process to their MAC. These referrals can come from a lot of different organizations such as RACs, UPICs, or OIG, for example. So if you got a OIG review, they could go through, they could clear you in the sense that they've determined that there's not an issue with whatever they were looking at, but still want your claims reviewed and then refer you to a TPE. MACs tend to target providers with historically high claim denial rates, if they have billing practices that vary from their peers, or when there's evidence that there's a potential risk to the Medicare trust fund. So if they're concerned about fraud, waste, or abuse, if they get a credible allegation of fraud or a report, these are all reasons why you might be audited or referred to a TPE. You can go on to the next slide. If you're selected for the TPE process, you'll receive a letter stating that you've been selected for review. The letter explains what the TPE process is, what you can expect, and also discusses the one-on-one education you're entitled to as part of the process. The letter will also discuss how the MAC has the option to refer patients to the RAC or to a RAC or a UPIC audit if you fail to respond to the ADRs that you receive. For each of the 20 to 40 patients selected, you receive an ADR. These are additional document requests. Probably everyone is familiar with them because they're fairly common. But you'll get one for each of the 20 to 40 claims that are received. And Christin will also talk more about ADRs later. These are often separate letters that you'll receive until the identified number of claims have been sampled, so the 20 to 40. So you'll get one letter for each patient. For the first round of the TPE, claims are selected based on your claim submission date, not date of service. However, after the first round, claims in the subsequent second or third round are selected based on dates of service. This is because they want to ensure you've had time to implement the education that they provide in your documentation. There's also specific notification language that's listed here on the slide that has to be included. The second bullet point is critical, though, because it discusses that CMS has the authority to revoke your billing privileges, your Medicare billing privileges, if CMS determines that you have a pattern or practice of submitting claims that fail to meet Medicare requirements. So if you have a very high error rate, they can revoke you. We're not really going to go into details about the revocation process or suspension, but suspension and revocation are the real risks you should be afraid of and aware of if you fail these audits. Revocation would mean that you're no longer have a Medicare number and unable to bill for any services to Medicare. With regard to that, it often has a trickle-down effect where many things, like if you have a contract with a private payer, they oftentimes have in there as well that you're required to be credentialed with Medicare. So if you're revoked from Medicare, you might not be able to bill really anyone. So it's kind of the final nail in the coffin for a lot of agencies if they are revoked. So these audits should be taken very seriously and making sure that you're passing so that something like that doesn't happen. Things that can result in revocation are repetitive errors. So if you continue to have issues or problems throughout the process, and this is another reason why it's really important that you're keeping up with your compliance practices, that you have a robust compliance plan in place, and that you're enforcing that so that all denials are addressed. You know, having a compliance plan that sits on your shelf isn't really beneficial if no one's following up on it or enforcing it. Okay, you can go on to the next slide. When you receive a records request, you should gather all of the requested records just like you would for any other audit. It's important that you go through and you check your documentation very thoroughly for completeness and accuracy, making sure that all requirement documents are included based on the types of claims requested. The types of documents to be submitted will vary, but some MACs have listed helpful guides on their websites. And you should also carefully review the letter you receive because sometimes additional information may be requested that you're not expecting, such as earlier records to support the current episode of care. It could be, you know, the initial documentation from admission. It's more than just typically the current episode being reviewed. So you want to make sure that you're providing all of that so you're not having denials related to something that it is unrelated to the care you provided and you actually have that record. Especially that could be a problem when face-to-face documentation is not submitted. And it's very important that you comply with the stated deadlines in each letter. Each claim likely will have a different due date. You know, a couple could be due on one day or things like that, but each letter will have their own deadline based on the date it's sent out. So it's recommended that you create something like a spreadsheet or some sort of tracking device to ensure that no deadlines are missed, because you would hate to have a denial related just to forgetting to send in the records, which could cause you to move on to the next round. So for something just silly like that would be a horrible reason to have a denial. And in fact, failure to submit records is one of the most common denials for TPE audits and really audits in general. Providers do frequently miss records requests, or they become overwhelmed with the vast number that they're receiving and misplace one or things like that. But that is the most common reason for denial. And not submitting records can result in a referral to a UPIC audit, which could be extrapolated and result in massive overpayments being assessed. So it's very important that someone is checking in and responding to all of these audits. You can go on to the next slide. When you submit your documentation, the MAC does a medical review to identify any concerns. If the MAC identifies an easily curable error, the MAC is supposed to contact you to provide, to give you a chance to address the error and allow the provider to submit any missing documentation. For instance, this could be an unsigned note, which can be easily cured with a signature attestation. However, not all missing signatures can be cured. For example, an unsigned 485 cannot be cured by an attestation because it has to be signed prior to billing as a condition of payment. So it's very important that you know what types of errors can be fixed or not. If a provider failed to submit some notes, those issues can be cured by, submitting them in a supplement or adding them in an appeal. However, you really shouldn't count on this. It's rare for the MACs to actually reach out and give you a chance to submit it. So even though that's what they're kind of supposed to do, it often just results in denials, and then your opportunity to cure it is with an appeal. And the appeals do not necessarily help you in the TPE process, as the appeals do not have to be considered to reduce your error rate, even if you end up winning those appeals. This is because the appeals process can take months, and you often will have already moved on to the next round of the TPE before you get a chance to resolve those outstanding appeals. So while you might end up winning all of your claims after you submit the documentation in your appeal, you've already started round 2, and they don't stop it just because you ended up winning. If the appeals are processed quickly enough or the rounds are delayed, it is possible that the appeals can reduce your denial rate, but that's up to your MAC and not a guarantee. We know at least one MAC who does put the second round on hold and would not proceed with the auditing process until the results of the appeals process were done. But this is unusual and definitely not something you should count on. But it is something to keep in mind that, if you receive a denial, you might want to get your appeals filed quickly to see if it will affect the error rate and maybe be considered before they move you on to the second round. TPEs are typically returned in 30 days for prepayment claims and 60 days for post-payment reviews. And these are just averages. They can vary widely based on how overwhelmed your MAC is or things like that. But that's kind of what you can expect. TPEs are supposed to be conducted by qualified individuals such as registered nurses, certified coders, or something along that nature. This means that they should have some qualifications before reviewing your records, but that does not mean that your results will make sense or that they truly are used to your services. This is often a bean counting experience. They have a checklist and are just looking for each item. It's not based on common sense or fairness or arguments that they care what's necessary or good. It's really about, do you need each box? Do you have what's required to be there in order to be approved? And if not, then you will be denied. And like I said, many times providers are upset because they believe, the patient benefited from the services, that they provided good quality care, and that, they should be paid for it. But that's just not how this process works. It very much is based on whether or not you meet each requirement or in condition of payment. Okay, you can go on to the next slide. So this is kind of a depiction of the TPE process, which we've already gone over. But you first get a letter saying you were selected, then you get told the 20 to 40 claims that are to be reviewed. You go through the medical review process. If those claims are denied, you get invited to a one-on-one education session. It's very important that you attend to this education. Some providers decline, thinking that they know the rules or that they won't benefit from the education. They think it's a waste of time. But it's very important that you attend and take advantage of the education to really understand why your claims were denied. You're allowed, it's encouraged, and you should ask questions. You're meeting directly with the reviewers who will be overseeing your audit throughout this process. So this is your best chance to really see how your MAC interprets their rules. As I'm sure you know, there can be some disagreement about what requirements mean. So hearing what your MAC believes will tell you what you need to do. And regardless of if your MAC is right or wrong, the quickest way to get your claims approved is to abide by their interpretation and what they're going to enforce. So you might disagree about something and how it needs to be documented or where it should be, but if your MAC is telling you that that's their expectation, you're typically better off just complying and updating your process so that way you can pass these audits. And I don't just mean through this one TPE, but your MAC until it's reassigned, which does happen, you know, time to time through the contracting process, but unless it's reassigned to another MAC who takes over that contract, you're going to want to comply with what they do for the most part to give yourself the best chance to actually get paid for the beneficial services you're rendering. After the education session, you're given at least 45 days to make changes and improvements. This is sometimes extended beyond 45 days, as I mentioned, especially if they allow you time to go through the appeals process. And we've had clients actually have up to a year between rounds. But you can't count on that extra time. You need to work swiftly as soon as you finish your education session to update your practices, ensure you'll pass the later rounds, and you know, be ready for what's coming. After a waiting period, a new 20 to 40 claims will be selected to go through the whole process again. So you'll move on to round 2 if you were not deemed to be compliant. After round 2, you get those audit results, you get education again. And if you are still not compliant, you will have at least 45 days again to implement the changes before moving into round 3. At any time, you could be determined to be compliant, though, and removed from the process. If after round 3, you're still found to not be compliant, you'll be referred out for other possible CMS action. However, if you're found to be compliant, you'll not be reviewed again for at least 1 year on the selected topic. That you can have multiple different TPEs, as I said, covering different types of claims or different types of services at the same time or one after the other, though. And you can still be audited separately by a UPIC, RAC, or other contractors. So just because you've completed the TPE process doesn't mean that you can, you know, sit back and take your hand off the wheel and assume that you're going to be fine. It's just specifically that you won't go through a TPE again for the same issue within 1 year, with the caveat that if your billing practices change significantly after they've completed their review, and so that you pop back up, they could come in even after you've completed the audit process within that 1 year frame to look at you again. So it's still important that, you know, you're staying on top of things, that you're not just getting through the audit and then going right back to how you were billing, that you're actually implementing these changes, because otherwise you're just going to end up in another review again, likely. Okay, you can go on to the next slide. So this is the TPE audit decision flow chart. It depicts some of the information that we were just discussing, but it shows how if you make it through the rounds, when you get out of the TPE process, or when you go on for possible further action, if you follow down along the flow chart, you really do not want to get to round 3. If you fail round 1, you know, this happens. It's fairly common. There's nothing to stress about. You get the education. Hopefully you modify all your practices. You meet with your clinicians, make sure that they're understanding what they need to do and putting together everything so that way you pass round 2. If you get on to round 3, I mean, obviously no one wants to keep getting audited, but there's obviously additional risk because that's the final round. You know, the risks of failing round 3 are potentially devastating. You could be sent on to any number of further actions, like a UPIC audit, which could be extrapolated or not, a suspension or a revocation. So these actions, all of them, a UPIC audit or suspension or revocation, can all end up in an agency having to shut down. Those some of the highest risk areas that you face. And therefore, you really need to engage with this TPE process and the education to avoid failing round 3 and facing further action. If you do move into round 3, you should not freak out though. Ensure that you take full advantage of the education that you got in round 2 and make all appropriate changes to ensure you pass the final round. Many people do feel more comfortable having counsel helping them through it because of the risk associated with it. And so that's definitely something that you might want to consider or look into to see if you would benefit from additional education or help in order to try to pass this process. You can go on to the next slide. These are some of the most common denials throughout the TPE process, and truthfully, pretty much all auditing in general, especially for home health and hospice agencies. The number one denial reason we see is missing or inadequate face-to-face documentation. The face-to-face requirements, they have changed over the years. That some people find them still quite confusing, but this has been a requirement for a very long time at this point. And yet it still remains to be one of the most common issues for agencies. It's required that the actual notes of the encounter be collected from the physician and that the primary reason for the services be documented at that encounter by the physician. This is, I know, difficult because it's outside of your control. It's coming from someone else. However, it's a requirement, and it's a requirement for payment. So therefore, you need to make sure that before you're billing for these services, that you have the records from the physician, that the records meet the requirements, and if they don't, then you can't care for that patient or bill for them. I know because of how face-to-face works, you could have been caring for that patient for a while, but again, you still cannot bill for those services if the documentation you receive does not meet the requirements, as that is a condition of payment and cannot be cured after the fact. You're working with providers that might not be responding to your request or things like that, and I understand the frustration, but it doesn't change any of this. You're still required to have it in order to bill. So you're going to want to make sure that if you have problem providers that aren't responding or don't give you it, that truthfully you just stop taking those referrals, because there's no benefit to having a patient if you're not going to actually get paid for those services. Another common issue is if the face-to-face is not being performed by the certifying physician. There are, of course, some exceptions, such as if they come out of an acute care or a mid-level who's working under the certified physician's supervision. But these arrangements need to be documented, so it needs to explain that the certifying physician has reviewed the face-to-face still. Another issue is failing to document the date of the face-to-face occurred by in the physician certification. It's recommended that you incorporate this date of the face-to-face into the 485 to ensure that this requirement is met. However, we've found that even when agencies incorporate it in and they have the box in the 485 that says, the date of the face-to-face encounter, it's often left blank, which is resulting in a large number of denials that I've seen recently. So you need to be conducting regular internal audits and reviews of your face-to-face and certification documents to ensure that all requirements are being met due to the high risk associated with these documents and the fact that these issues cannot be rectified after the services have been billed. You can go on to the next slide. After you complete each round, as I've said, you get offered one-on-one education with the auditor. This can be completed via phone call or over a webinar platform. It should be noted that if you call your MAC after you receive your results, sometimes they'll do some sort of informal discussion with you and then write that down as if you've received your education. Make sure you are clear that if you call in that the discussion you're having is not your education until you're fully prepared for that discussion. You want to make sure you have fully read the results, you have a list of questions, and all the people you want to be present are there and able to engage and receive that education. We've had clients call the auditor and just have like a quick 5-10 minute phone call and the auditor wrote that down as their education refused to do any more. So that's something that you definitely want to be in front of and document. These calls are genuinely for your education. So if the reviewer is going too quickly, if they're using language you don't understand, if they cite some rule you've never heard of, you need to ask them to repeat themselves, explain more, slow down, or give you a copy of that regulation so that way you can make sure you understand and have incorporated it. Okay, you can go on to the next slide. Education should be individualized, so they should be claim specific and conducted in a format that is interactive. So you should be able to engage and ask questions of the reviewer. Anyone can be on the call with you. So if you want to have critical members of your organization participate, anyone who's in charge of compliance, it can be your biller or your legal representative. Any person who you want is allowed to participate. You should, like I said, ask for any rules or regulations you don't understand. Ask questions if you don't understand a denial. You can use the actual details from the claims they reviewed to discuss and make sure you understand what they're saying. And that way you can make sure you can implement those fixes for the next round. And go on to the next slide. At the end, you receive a results letter. This says why the claims were denied, including the specific errors you had. This is, you'll either be given or can calculate sometimes your error rate at that time. It also includes the details of how to appeal any denied claims. There are strict deadlines associated with appealing denials to be complied with. Deadlines for recoupment will be earlier than the deadline to appeal the denials. So make sure you're carefully reviewing all letters and demands, the letters that you receive, to avoid any surprises, and don't have, claims recouped if, you're appealing them or things like that. And you should definitely appeal any denials that you feel were wrongly granted. Go on to the next slide. You can be referred to CMS at the max discretion after 3 rounds of TPE. However, you can also be referred to a UPIC at any time. They do not have to wait for you to complete the 3 rounds. So if something is very concerning to your MAC or they suspect fraud from the review, you can be referred out for a UPIC who may choose to conduct an audit of a statistically valid random sample, which then can be extrapolated across all the services you provided for that period of time, which can result in overpayments of hundreds of thousands or even millions of dollars. This is why we recommend hiring external assistance during this process. It's in the interest of all parties to have assistance from the beginning, as it'll help your ability to lower your denial rates and hopefully exit the TPE process prior to a later round and without any referrals. Also note, if you refuse the education that's offered during the TPE process and you're referred out to CMS or the UPIC, that refusal will be noted typically and can be used for negative inferences about your agency. So again, it's very important that regardless of how you feel about the education, that you receive it and participate. All right, you can go on to the next slide. If you have a sufficiently low error rate, you can be removed from the TPE process after any of the rounds. After the TPE process, the MACs continue to use data analysis to monitor your billing practices. If your billing practices change or revert back to what they were before the audit, that'll be noted and can result in a resumption of the TPEs or further action. Your error rate can be calculated a few different ways. It can be based on the dollars denied versus dollars that would have been reimbursed if the claim was paid. It can be based on the specific number of claims denied. So for instance, if you had 2 claims denied out of 20, that could be your error rate, or some mix of these processes. Each MAC chooses their own to how to calculate denial rates. And they determine what their acceptable denial rate is to get out of the TPE process. So this can vary based on what jurisdiction you're in, but again, you're going to want to just try to get as many of your claims approved as possible. You can go on to the next slide. These are some examples of at least what they have said in the past of what their error rate thresholds are. from different MACs. These could have changed. These were collected during previous cases we've worked on. For example, Palmetto, if they're your MAC, they had less than a 20% error rate, you could be removed from the TPE process. But if you hit 21%, you would continue to the next round. And so each MAC will set their own error rate, and they may or may not be willing to tell you that. You can go on to the next slide. These are some compliance tips. We recommend that you find your MAC's TPE webpage, and then you can review topics, dates, documentation checklists, and educational info that they might have on there. Make sure your point of contact is correct and up to date in PICOS. They use this to contact you, and if your information is inaccurate, you could miss vital communications, you could miss audits. It could result in massive issues for your agency, so make sure that you're updating PICOS. You need to conduct internal reviews of records before submitting them, checking to see if any additional documentation should be included, and making sure that everything is complete and accurate that's being submitted. You need to respond within the notice letter's time frame. Like I said, create a spreadsheet or something to make sure you don't miss any due dates. Do not refuse the education. Make sure that everyone who needs it receives the education and makes the necessary changes. You may need to gather all of your staff to make sure the updates are timely communicated because of tight timelines. Identify what changes to your policies or procedures are needed and then make those. Okay, you can go on to the next slide. So this is kind of a depiction of the ADRs versus TPE audits. ADRs are part of the TPE process because you receive additional document requests for the 20 to 40 records that make up the TPE. However, they're also a separate audit process that can occur at the same time or completely separately from your TPEs. Plain ADR is less risk because it's just typically one claim. It's not part of an audit system. However, ADRs can result in a referral for further auditing, for instance, for a UPIC or a TPE. So they should still be taken seriously every time they're received. TPE reviews more claims and therefore are higher risk. You can be in multiple TPE probes at the same time. You can receive multiple ADRs at the same time and can receive both at any time. So multiple audits or types of audits can occur simultaneously. So you should always be aware of that and tracking it and making sure you're responding to all. Christin will now take over to discuss the ADRs and some other auditing processes.
Thanks, Megan. Next slide. Okay, so additional document requests are part of Medicare's overall medical review program. Authority to request additional documentation can be found in various sections of the Social Security Act, like sections 1883E and 1814A. The most important thing to understand is that a MAC has the authority, to review any claims at any time. As a Medicare participating provider, the cost of doing business is that you're going to get audited. It's not a matter of if you're going to get audited, if you're going to avoid it, it's a matter of when and whether you're ready when the time comes. Next slide. ADRs are done prior to payment of a claim and are usually handled by the MAC, although some can come from other contractors. There are various reasons that providers receive ADRs. An element of a claim might need a prepayment edit. It could be a national edit. There could be a specific national review focusing on a particular ICD-10 or CPT code. We're seeing a lot of these program-focused ADRs right now. It could also be a provider-specific edit based on reasons or edits developed by the MAC's internal medical review or program integrity unit. All prepayment edits can key in on a beneficiary's number, provider's NPI, service date, CPT or HCPCS codes, and ICD-10 codes, among other data points. Next slide. MACs must be able to review a claim in an apples-to-apples manner. For example, the standards of one procedure, diagnosis, or place of service type cannot be used to determine the appropriateness of another. This is particularly tricky when the reviewers are assessing a family of codes, and special attention should be paid to the similarities and differences for distinguishing codes within those families. Next slide. For ADRs, you're going to receive a letter sent to the address on file. You need to make sure that this address is current. An ADR has a 30-day response deadline. So if your address isn't current, then you can run into issues when you're not able to file things in a timely manner. One MAC states documentation received after the 30-day deadline may not be completed within the 45-day review window. And if a provider fails to respond by day 40, the claim can automatically be denied. The timeline is critical. One of the major denial reasons related to ADRs is that documentation isn't received. It's hard to believe that a provider wouldn't respond to an ADR that they did actually receive. It could be the quick timelines are the problem, along with gathering the requested records and submitting them. It is really important to be aware of those deadlines, like Meaghan was discussing with the TPEs, and to make sure you're getting the documents submitted in time. You can always supplement, which is important as long as you make sure that you put your ADR cover letter on those supplements and make sure it's fairly clear to the contractor that you're submitting these as supplements. What I have found most recently with ADRs as far as being received and timely response, some providers and agencies are not receiving the ADRs by mail. Some are receiving them via the portal for their MAC, and you'll need to be checking both places for those kinds of documents on a regular basis to ensure that you are staying on top of what documents are being sent to you and what requests are being sent. Next slide. This is a quick visual of submitting the ADR. You're going to send each ADR packet separately. The ADR cover letter should always be included and put on the top of your record. It can be helpful to submit the documentation through the electronic portal. It will get there instantly. The processing times are faster. You get the results faster. You get paid faster to the extent your claim is determined to be payable. I'm old-fashioned. I send everything by mail. It's your preference on whether you use electronic portal or mail in your response, but in either case, always keep a copy of your record. Many providers don't do that, and when a claim gets denied, they bring us on board and are unable to provide an exact copy of the files submitted to the MAC. A lot of times they'll offer to re-pull it from the EMR, but we can't be sure that's exactly what was sent to the MAC. As a result, we don't know with certainty what the MAC is looking at. So it's really, really important to keep a copy of those records on file that you've submitted in response to an ADR. If the MAC overlooks something, we can say we have a copy of the record, we have the page numbers, and we can point them to the specific spot in the submitted file. The reviewer could say a record is unsigned, but we can point to the physician's signature on a specific page, for example. And that's a quick way to correct a wrong assessment on the part of the reviewer and get an easy win. Be sure to pick up the phone and call the MAC with any questions. They do have a provider education department and provider resource line. So it's always worth asking, particularly if you've identified a mistake and it's something that's easily correctable. One of those easily correctable denial reasons, when they say the records aren't received, but you have submitted them and you've kept a copy of your delivery receipt, your proof of delivery. Send that in along with a copy of the record, and a lot of times they'll reopen that decision for review. Next slide. So what's the difference between receiving an ADR and being placed on prepayment review? ADRs are typically initiated by a provider's MAC, and they typically relate to a particular probe or edit conducted by the MAC. They can be focused on specific services, lengths of stay, a provider-specific diagnosis, or other reasons. In contrast to an ADR, being placed on prepayment review is usually going to affect 100% of your claims, and it can last a year or more. It's an intensive process, Rarely less than all of your claims are going to go through the review, and it's going to affect the revenue stream for provider or agency. Next slide. For prepayment reviews, UPICs will typically send notice to the provider if they're selected for review. However, we've seen quite a number of providers who've never gotten a notice before, who've just started receiving requests for documentation, which can be alarming. There is a provision in the Medicare Program Integrity Manual that says they should provide notice, and you should push back and make sure you get that documentation if you have not received it before you start receiving requests. Private payers are increasingly placing providers on prepayment review. And unlike Medicare and other governmental payers, very few private payer contracts go into very much detail on their processes. When it comes to how the provider may be placed on prepay, they also typically don't address the scope of a prepayment review. So it could be very uncharted territory to get into a prepayment review with a private contractor. From a practical standpoint, the payments can be delayed up to 6 months or longer. So we want to make sure that where possible, we don't jeopardize that revenue stream. All right, next slide. With any audit, our advice is always the same. Never ignore the problem and review the claims and associated documentation before you send them. There are many of the things that we pointed out before. Make sure medical necessity is substantiated. Make sure the services billed are documented. Make sure the documentation complies with your local coverage determinations or national coverage determinations. If they don't, if they're missing elements, go to the provider to prepare an addendum in line with the Medicare record keeping principles. We want to make sure that we fill in those gaps whenever possible. Clearly marking these as addendums, not altering the original documentation, making sure they're signed off with the date that the addendum or correction is made, are crucial to making sure these things are accepted. If your providers are doing all of that, they're able to make the addendum to their documentation to clarify, to correct, or to elaborate. Of course, there are limitations to what can be corrected, as Meaghan talked about earlier with the 485s. But for documentation purposes, as long as we're following those Medicare guidelines, most can be clarified, corrected, or elaborated on. It's important to take advantage of the initial review of documentation that you're doing before you submit this to the MAC, and it becomes a part of the administrative record. You also want to check whether the claims are coded, billed, and paid correctly. We think so much about documentation being the patient's narrative, but we also want to make sure that the back end affecting payment is also reviewed. Personally, when I review a claim, I always have the claim form and the record side by side. I want to make sure that every ICD-10 code that's linked to a CPT is supported in the record by proper documentation. If I notice that there are discrepancies between one and the other, then I can look to see whether there's been an omission, there's been an error, something needs to be clarified or corrected. Having those two documents side by side when I do my initial review before submission is extremely helpful. And it also helps to ensure that I've pulled all of the documents that have been requested to be responsive to the ADR. Next slide. So what is a post-payment review? Post-payment audit occurs after a provider has submitted a claim to receive payment. Basically, they're looking at claims that have already been paid. To the extent there are any issues determined, for example, eligibility requirements weren't met or the claim isn't supported, they would then ask for that money back through a demand letter. There are a lot of different sources for post-payment review. We're seeing a lot of data mining, and of course, contractors can basically look at that data however they want, which makes it easier for providers to get selected for the post-payment review. I like to tell everybody that comes to me with a new audit, it's not personal, it's just computers picking numbers. Some of the things they might see when they're looking at that information: are you billing more than your peers? Did you have a change in your reimbursement last year to this year? There's so many different ways they can look at it, and it's really one of the big reasons that providers get targeted for post-payment review. You can be placed in post-payment review because of complaints or referrals. We just don't see it as often. When you get a post-pay review notice, one of the first things we do in our firm is that we file a Freedom of Information Act request. We want to know what's going on. Where did the source come from? Was it a referral? Was it a complaint? Or was it the more common reason? Is it a data mining source? It takes a long time to get that information back, but eventually we do get it, and it can be very, very helpful in narrowing or identifying what the scope of the review is. Sometimes we get some very specific details from the contractor's investigative file. Some of these are extremely delayed and may not necessarily be helpful in this specific audit that's ongoing at the time. However, it can give you a great deal of insight into where you may have compliance deficiencies and may need to strengthen some of your internal processes and policies. Next slide. There are several big concerns with post-pay reviews. The money's already been paid and used for overhead and salaries. Now the payer is asking to get that money back. Getting the money together when it's demanded from the provider can be very difficult. Post-pay audits are sometimes extrapolated. When overpayments are extrapolated, you may be talking about a lot more than just the sample of claims that's been submitted, depending on the error rate and universe of claims. We see too often several thousands of dollars quickly become hundreds of thousands of dollars. There are oftentimes lots of errors identified per claim, each of which must be reversed for a claim to be determined to be favorable. So when you go through the appeal process, you might be able to win the face-to-face issue, but then you still have to prove the medical necessity and overturn that denial rationale as well. The more denial reasons you have, the harder it is to win them because you're trying to defend multiple aspects of the claim. Medicare can deny your claim for any number of reasons. In order for you to get paid, you have to win on every single denial that they bring to the table. I like to make a list and write down for each claim what the specific denial rationale is, so I make sure that I can highlight those areas in my appeal that address each and every one of those rationale. I find that doing it in a systematic way is the best way to ensure that each of them is being addressed, and it affords the best opportunity to have an unfavorable decision reversed. Okay, next slide. So this is just a quick snapshot of some of the CMS appeals statistics. It's always important to look at these. One of the main points is it's better to get this all sorted out in the medical review process, respond with solid documentation, and get your claim paid or to stay paid, because going through the appeals process is long and time consuming, and also you might not win. If you look at 2012 and then at 2020, those numbers have dropped dramatically for fully favorable and partially favorable. You don't want to get into the appeals process. It's incredibly long. You have multiple levels of review, and each of those takes months to complete. Next slide. So suspensions. If a provider is placed on suspension, it means the provider will not receive payment for claims submitted to Medicare for up to 180 days. Suspensions are terrible. Your revenue stops, and it's going to stop for that minimum 180 days, but sometimes suspensions are extended when the contractor hasn't completed their investigation, and that can double the length of the suspension to a whole year. You might be getting paid for claims, but the money's held in escrow until the investigation is complete. So even though claims are going through, you're not getting any of the funds. When your payer mix is heavily Medicare, this is a huge amount of your reimbursement, and can be debilitating if you're not getting paid. There are several different reasons that a provider can be placed on suspension. One of the most common that we see are credible allegations of fraud. Next slide. So what is a credible allegation of fraud? Unfortunately for providers, the barrier to establish this for CMS is extremely low. It could be based on a probe audit. They'll tell you that the medical review results for the probe audit weren't satisfactory. It could be a hotline complaint, more of that data mining. It could be from a law enforcement investigation. When you receive the suspension notice, the letter generally references 5 or so claims and will note the documentation didn't support that the services were medically necessary. This can be their credible allegation of fraud, and you are suspended for 180 days. They don't have to tell you anything about their actual analysis or how they applied the Medicare coverage criteria in your rebuttal. You could take that opportunity to respond to those 5 claims that they did identify, but again, we often see the investigation that's occurring during we often see that there is an investigation that's occurring during the suspension, and it's going to take the full 180 days in terms of knowing whether you're suspended. You're going to get a notice letter, but they usually send it on the day of or the day before the suspension actually occurs. So effectively, you don't really have notice. Basically, on March 24th, they issued the letter, and on March 25th, you received the letter and find you were suspended yesterday. Next slide. As I mentioned, after receiving notice of a suspension, you do have the opportunity to submit a rebuttal. We always recommend submitting one, even though it doesn't often result in the reversal of the suspension, because it is part of your defense. They're giving you some of the allegations, even though those are generic and they're only related to those 5 claims. It is your opportunity to respond to them, to collect and submit additional documentation. Sometimes they say we interviewed beneficiaries who tell them they didn't receive the services. You could potentially go back and ask those beneficiaries to sign affidavits. If they agree they received the services, you can do things to begin your defense. When they finally release you from suspension and you go through the appeals process, you have the best documentation you can and you're ready to support those services. Next slide. Some conclusions here. The potential results of a bad audit can be increased likelihood of post-pay review, overpayments, repayments, cash flow shortages. It could lead to suspension of your Medicare payments. We know how difficult that can be, and it also could lead to revocation, which is an entirely different administrative process that takes an entire hour to discuss, but we are seeing it more frequently. The things you can do to minimize impact of these types of audit and suspension mechanisms is to start compliance now. If your agency receives any kind of notice of prepay, postpay, or suspension, get legal counsel involved immediately. The sooner you do, the sooner that providers get back to business as normal. You really need someone who knows these processes and knows what it takes to go through the audits or the suspensions as fast as possible. More than anything else, never ignore a notice from Medicare. It won't go away, and it's a basis for them to escalate to more severe administrative actions later. Okay, I think that is everything for Meaghan and I today. I don't know if we have any questions, but we have another minute or so, Alex, if we do.
No, there's no question.
Fabulous. Well, thank you everybody for attending today, and we will look forward to hosting again soon. If you think of any questions in the meantime, feel free to reach out to myself or to Meaghan. Our contact information is on the screen.
Awesome. Well, thank you so much to our presenters, and thank you to our attendees for joining us today. I'll be sending a copy of the PowerPoint slides tomorrow. If you have any further questions, please feel free to reach out to either Meaghan or Christin. I hope you all have a great Tuesday. Thank you.
Thank you, everyone.